I'm Todd Park. I'm the Chief Technology Officer of HHS. The first thing you should know about me is that my job title is a giant red herring. I do not run technology at HHS. I was actually recruited for a position that they recently created about 20 months ago to be an entrepreneur in residence. And that actually was the phrase that really got me interested, because when they first called me, I was wondering why they called me, because I'd never worked in government before. I know nothing about government. But they said, actually, we are calling you on purpose because you're an entrepreneur, and we want to create an entrepreneur in residence position. And your job is to be 100% focused on being a change agent, to create and lead major new projects at HHS that help HHS harness the power of data technology innovation to improve health. At which point, we moved from here, which is an incredibly lovely place. It's so wonderful to be here today. And I'm doing my tour duty in DC. And what I'll tell you, and this may be shocking to you, but it is not hyperbole, is that the last 20 months have been the most entrepreneurial experience of my life by a significant margin. At the root of it, HHS is thinking very entrepreneurially about how to spur entrepreneurship. And that's what I'd like to talk about today. So I would submit to you that right here, right now, there's never been a better moment to be a healthcare innovator in American history. Why is this? It's because two mega trends, which I've been waiting for personally since I was a small child, are finally locking in epic form and scale. The first is massive incentive change, which has begun, which we'll talk about. And the second is information liberation, which is also locking in multiple exciting respects. Collectively, new incentives and information liberation equal rocket fuel for innovation, rocket fuel for entrepreneurs, rocket fuel for change in American healthcare. So let's talk about each of these trends. The first is new incentives. Have you heard about meaningful use? Who here has not heard about meaningful use? Okay, so for those of you that haven't heard about, make a very long story short, as part of the Recovery Act, there's a sub-act called the High-Tech Act. Essentially, it authorizes Medicare and Medicaid to pay bonuses of $44,000 to $63,000 per doc, or $2 million per hospital, for the adoption and meaningful use of electronic health records. This is very, very exciting for multiple reasons. It's a giant impetus toward the adoption and use of electronic health records. It's very exciting as well because it doesn't actually pay you just for buying the technology and showing Medicare the receipt. You actually have to use it in ways that improve care. And the standard for what that means, improving care, has been defined through a very open public process. Initially, it's capturing the right data about patients and sharing it. It's moving to then clinical process improvement, and then finally to improved outcomes. And this is fantastic. But it's just an appetizer. It is absolutely not the main event. The main event, which is actually not broadly known, shockingly, even in healthcare, but it's becoming more broadly known, hopefully, is the Affordable Care Act and what it's doing to change how providers will be paid in America. I would submit to you that if you really want the health system to change, if you want to actually optimize quality, efficiency, and health, you have to change how we pay for healthcare. Does everyone in the room know how we pay for healthcare today? Well, for those of you who don't, the way we pay for healthcare, the way we've always paid for healthcare is by the yard, right? By the piece. We pay per physician visit. We pay per hospital stay. We pay per surgery. So what do you get? The rule of the market is you get what you pay for. We get rapidly escalating volumes of doctor visits, surgeries, and hospital stays. So far from our system being dysfunctional, I would argue it's functioning perfectly. It's delivering exactly what society wants it to do, as signaled by payment. So the problem is that these rapidly escalating volumes of services are famously not correlated with rapidly escalating quality of care, health, and outcomes. And that is the pickle that we're in today. So the thing the Affordable Care Act does, which I believe is the single most important feature of the whole law, is it actually authorizes, directs, and funds Medicare, the biggest payer in the country, to shift how it pays from pay for volume to pay for value, to pay for health, to pay for quality. Unless this happens, innovations that improve quality and efficiency are never going to take hold. Because if you actually introduce an innovation in today's healthcare system that improves quality, that helps people stay healthy, prevents them from being readmitted to the hospital, prevents them from being in the ER, that's actually a negative business case for the healthcare system. It can't really adopt that because it loses money by doing so. So it's a wish somehow that the health system will actually try to become more efficient and higher quality, right? To wish that it actually will become higher quality, more efficient in such a fee-for-service reimbursement system is crack smoking. It's never going to happen. But if you actually morph how you pay from pay for volume to pay for health and value, I predict and we're all beginning to see this, that you'll see some remarkable momentum toward efficiency and quality. We'll talk more about that in a second. And there are a whole series of provisions in the Affordable Care Act that actually underpin this megatrend. So there are accountable care organizations, patient-centered medical homes, bundled case rates, et cetera. But the fundamental punchline is that they incent quality, they incent efficiency, they incent health, they incent working hard to keep people out of the ER, out of the hospital, and fund the work required to do that. And the most important provision of all is something called the Center for Medicare and Medicaid Innovation, the CMMI. Sachin Jain, is that you? So I have to come to California to meet you? Sachin is a key player in the CMMI, the New Innovation Center, which is actually, I think, the best kept secret in American healthcare, but rapidly becoming more broadly known. An incredibly important organization to understand. The CMMI is a new center set up within Medicare, which has been given $10 billion to identify, validate, and scale new ways of paying for care that are NPV positive for Medicare, that actually improve quality and lower cost. The most important thing to understand about it, in my opinion, is not the $10 billion. It's actually a special power it's been given by the Affordable Care Act that Medicare's never been given, which is the following. If it identifies a new way of paying for care that the CMS actuary validates as lowering costs and improving quality, and the CMS actuary, for those of you who don't know, is famously apolitical and lobbyable, right? Does not give a crap about anything but the numbers and the results. If the CMS actuary says this is cool, then the Secretary of HHS has the ability to turn that into national Medicare payment policy through the rulemaking process. It is the most scientific, evidence-based process for changing how Medicare pays that Medicare has ever been given. And I would submit to you that the reason why Medicare has not changed how it pays is not because the people in Medicare don't want to do it. They've known since they were small children that they need to do it. It's Congress has never given them the authority to actually pursue a rational redesign of payment. But now Congress has given them that process, and that is a big, big, big deal. And I can tell you, on behalf of HHS, that we think this is the ballgame, that we are going to be using this authority, the Innovation Center, the funding to really drive how Medicare changes payment. And why is that a really, really big deal? It's not just because Medicare is a big payer. It's because the private insurers tend to copy what Medicare does. In this case, they're saying, hallelujah, it's about time, because we've been trying to do this forever, but we can't because Medicare continues to pay fee-for-service. And doctors can't function half in a world that's fee-for-service and half in a world where they're trying to proactively optimize health and proactively coordinate care and do a whole bunch of stuff that the fee-for-service system actually doesn't pay for. So by Medicare finally moving in this direction, it actually unlocks the desire of all the other payers to do the same thing. And so you'll see in the next 2 years a huge change in payment. This is actually, in my opinion, one of the most powerful disruptive changes in the history of American healthcare, and it's going to be a big, big, big deal. So why is this mother's milk for innovation? Well, if you actually think about the new kinds of care delivery systems that have to arise, as you think about how an industry has to morph from a mindset where it's essentially optimizing throughput and seeing as many people as possible to one where it's actually proactively monitoring the health of its population and its patients, understanding what care people have gotten, identifying gaps in care, filling those gaps, coordinating with other providers, keeping people out of the ER of the hospital. I mean, that's a very, very big shift to go from fee-for-service, essentially table turn, throughput maximizing operations to proactive population health maximizing operations. The great news here for innovators and entrepreneurs is that that's a huge opportunity. That's a huge opportunity because actually to do the kinds of things I just said requires a whole bunch of muscles that doctors and hospitals don't have today. The ability to actually aggregate data, mine it, identify gaps in care. The ability to actually do decision support so you do the stitch in time that saves the ER visit. The ability to actually coordinate, integrate care across lots of different providers. The ability to extend the reach of the physician outside the walls of the physician's office into the home and in other settings. The ability to engage consumers to get them engaged in their care, help them stay compliant with their meds, potentially using some of the tools and insights from the previous two presentations. This is actually very exciting because actually these muscles, while they might seem like a stretch to doctors and hospitals, are muscles that have been built in other sectors and perfected, and there's a massive opportunity to actually transpose these muscles, translate for healthcare, into the healthcare space. It's an opportunity, in a nutshell, to re-instrument a $2.5 trillion industry to actually not optimize for volume, but optimize for health. I think it's the greatest entrepreneurial opportunity since the internet, and one that will actually change the course of American healthcare and create huge economic value at the same time. So that's trend number one, is incentive change. Really, really big deal. The second mega trend is information liberation. There are three parts to information liberation. The first is a rising tide of patient data liquidity. So what this means, in a nutshell, is that the information that was in manila folders in doctors' offices, as we previously mentioned, bless you, is going electronic. But it's not useful, really, unless those electrons can move, right? If all we do is move from paper chart rooms to electronic chart rooms, where the electrons cannot move around, that's not incredibly helpful. So there's a bunch of work that's actually happening to ensure that the electrons can, in fact, move around. So have you heard of the DIRECT project? Anybody here heard of the DIRECT project? The DIRECT project is actually a great illustration of government 2.0, how HHS is rolling in the contemporary era. So this is actually a very interesting story. So there was a hearing, a public hearing, where a doctor testified in front of a committee and said, look, I've got this problem. I have an electronic health record. I have a patient I want to send to another doctor who has an electronic health record. In fact, we both have the same electronic health record from the same company. How do I get this patient's record from me to the doctor, the other doctor? And he said, actually, literally, the only way I could figure out how to do this was to print it out and fax it. So she would type it into her EHR. He said, but of course, this is insane. So he actually ended up emailing it, at which point the committee had a heart attack because he broke 3 laws in the process. And he said, look, I understand that was bad, but look, I know you guys are thinking all these fancy thoughts. Can you just help me with this fundamental problem? How do I get the record from me to her? And so he said, well, we can help you with that problem. But instead of actually appointing a blue ribbon commission of government eggheads to think really hard about in a conference room, we actually did the opposite. We challenged the country to come up with the answer. So we announced that we were convening a collaborative called the DIRECT Project Collaborative. We created a wiki space and a series of public meetings where anyone could come together, anybody could come together, and join the collaborative to solve the problem. Over 60 private sector companies came together to solve the problem, including people who were blood enemies of each other. But because the government was providing a neutral, honest broker convening ground, they actually agreed to work together. Within less than 90 days, they came up with a spec for secure healthcare email, simple and brilliant. A few months later, they had it in production. And now, over 70 companies, I believe, representing over 90% of the electronic health record marketplace, have committed to implement direct email this year. This is all basically within a year this happened, with actually microscopic government investment, just convening the industry to come up with an answer super quickly, and one that actually is producing very practical results. A second project I just want to talk about is called Blue Button. Have you heard of Blue Button? Blue Button is another very simple project that we actually launched relatively recently. And it turns out that the Veterans Administration, Medicare, and the Department of Defense are 3 of the largest repositories of personal health information in the world. Medicare has records of claims payment for 47 million seniors, and the VA and DoD deliver healthcare directly to several million people, veterans and members of the military. So Blue Button is this capability where essentially we gave each Medicare beneficiary, veteran, and member of the military, the ability to download a copy electronically of their own data. So you can go to a website, authenticate yourself, and hit a blue button, that's what it looks like right there, and download a copy of your information. This took us about 17 lines of code. It was very easy to do, but it's actually become a really big deal because in the private sector, this is not necessarily common. The ability to actually download a copy of your own information and then move it wherever you want is not common. In fact, we had, after we deployed this in beta in October, we had private sector folks call us and say, was that legal for you to do? Isn't it a HIPAA violation to actually give a patient a copy of their own information electronically? We said, dude, we're the US government. If it were illegal, we probably wouldn't have done it. But it illustrates the level of confusion about this. And so more and more private sector folks are actually now doing this. And we've actually not marketed this at all. But since October of last year, actually now 300,000 unique users have downloaded a copy of their own data and are uploading it to personal health records, and other applications are being built to actually suck up this data and make it useful. So rising tide of health data liquidity, because that's very important to feed the instruments that will help doctors and hospitals understand what the hell is going on, coordinate care, and do the stitch in time that will save the ER visit or the hospital admission. A second component of information liberation is market transparency. What defines a market? I would submit to you that actually a market is characterized by knowing price and performance and the ability to actually make a choice based on price and performance. If that's the definition of a market, is healthcare a market? Not so much. So one of the other things the Affordable Care Act does, the health reform law, that's very important, that's actually also not really that broadly known, is it brings massive new transparency to the market. There's a site called healthcare.gov we launched last year. I was in Paris on vacation, and I got a call from my boss. And he said, Todd, the White House just called. They want you to lead the building of a site called healthcare.gov. It's supposed to have every single private and public insurance plan in America on it, and it has to be built in 60 days. I said, Bill, what? He said, but feel free to work on it after you come back from vacation. And I said, Bill, I should have started working on it 6 months ago. But long story short, we pulled together a team of folks, and we pulled the site together. And it's the first site that actually compiles every private and public insurance plan in America, benefit information. October, we added pricing information so you can compare them against each other. There have been other sites, like ehealthinsurance.com, that have a subset of the data, but those are voluntary sites. Because only HHS, only the government can actually say if you're an insurer, you're required by law to actually disclose your products, pricing, and benefits. And so that's why we were able to create this comprehensive inventory. On the provider side, the government's actually been compiling for some time now hospital, nursing home quality data. We're actually now going to be compiling physician quality data, all through a very open public process, talking with docs, consumers, experts, et cetera, and publishing that data as well as deepening our hospital compare and other modality quality data to, again, bring more transparency into the healthcare provider marketplace. And the final component of information liberation I want to talk about is the Health Data Initiative. Have you heard about the Health Data Initiative? This is amazing, actually. It's interesting because this is a group of healthcare folks who are actually very sophisticated, very, very smart, who are building companies, running actually major provider institutions. And a lot of what I've been talking about is actually not stuff you've heard about. And this is what I've been telling people in DC. I said, look, all the policy in the world isn't going to help anybody if nobody knows it's there. If the policies we're trying to actually implement to help spur innovation are not known by the innovators, that's not very helpful. So it's great to have a chance to connect with you today. And actually, I'd love to brainstorm further about opportunities to carry the message further. So the Health Data Initiative is actually a really big deal. And to make a long story short, the gist of it is, are you familiar with NOAA? The National Oceanic and Atmospheric Administration? So NOAA collects, it turns out, virtually all weather data in the United States. And it turns out that it does something very interesting with this data, which is it chooses to publish all of it online in machine-readable format, downloadable by anybody for free without intellectual property constraint. That then feeds a whole bunch of private sector innovation. Weather Channel, weather.com, weatherspark.com. I was just talking to Vinod Khosla, who's started a crop insurance company, which is growing like crazy, weather bill, based on NOAA data, nightly newscasts, et cetera, none of which the government has to pay for, none of which the government choreographs, and which creates huge value for the American people. So we said, that's awesome, and the government's actually run this play previously with GPS data, right, by releasing that, which then spawned tons of innovation, financial data, which spawned tons of innovation. So we said, let's run that play for health data. And as an experiment, last March, we pulled together a small meeting of about 45 innovators, a mix of healthcare rock stars and tech rock stars like Don Berwick and Tim O'Reilly. And we said, look, we've got this idea for HHS to become the NOAA of health data, because we've got tons of data. Is this a colossally stupid idea, or does it have legs? They got very excited about it. We said, okay, let's start with a limited set of data. Community health data, national, state, regional, local data on smoking, obesity, access to healthy food, and hospital and nursing home quality data. Right? If we release that data in a form that was really easy to find, really easy to use and work with as a developer, what would you do with it? They brainstormed about 20 classes of applications that they would build that could use that data to help consumers, doctors, employers, mayors make better decisions and improve health. And we said, okay, well, in less than 90 days, June 2nd, Secretary Sebelius will host a giant public Lollapalooza. Any of you who can build one of the apps you brainstormed will showcase you and make you famous. We weren't exactly sure what would happen next, but what happened next was these innovators rose to the occasion, and their friends and their friends' friends, and on June 2nd, less than 90 days after that initial meeting, a week after that initial meeting, we actually put the data sets we talked about in a very easy to find, very easy to use form on the website. Less than 9 days later, they debuted 20+ brand new or upgraded applications leveraging our data that were amazing. So I'll just talk about a couple of them real quick. So one of Tim O'Reilly's laws about how data changes people's lives is if you want data to help people, don't make them find it. Make the data find people where they already are, where they're making decisions where the data can be helpful. So Bing took this to heart. They actually took our hospital compare data, which is awesome data. It's like hospital by hospital quality of patient sat, which nobody knows about, and we actually deploy it on a website that nobody goes to called hospitalcompare.gov. They actually download the data and they integrate it into search. So for a bunch of hospitals, not all, but for a bunch of hospitals, if you type in the name of the hospital, it pulls up in the primary search result the patient satisfaction with that hospital versus the average. I just use this to determine the hospital that my wife will deliver our second child at. And it's incredibly useful. And I've actually, I must confess, I've never been to HHS's Hospital Compare website. I wouldn't know how to use it if it found me. So this is actually really, really interesting. A company called iTriage, which is a really awesome handheld, find medical treatment, learn about procedures, research diseases, find doctor app, integrated our community health center directory into it, options for free and low-cost care. And they've gotten tons of people using iTriage since June 2nd last year to find free low-cost care options, again, without us spending a dime. People built dashboards, analytical tools to help employers and communities and health plans understand where issues were and where investments could be made. People built games. This actually, I just want to talk about this. This is called CommunityClash.com, a startup called MIU Health in Boston, wholly owned by Healthways, a disease management company, built this in 14 days. It's healthcare blackjack. So essentially what happens is you go to CommunityClash.com, you pick a city, like Boston, you pick an opposing city like New York, and you are dealt 5 cards face down, each of which corresponds to a health indicator, like smoking or obesity. You're allowed to substitute up to 2 cards out for other indicators where you think you beat New York, then you show your cards. And that may sound silly to you, but actually in the expo, after the main presentation session where you could sample yourself any of the apps that you want on June 2nd, the longest line by far was for this game. It is strangely addictive in a way I can't explain. And the reason why I think this is important is because it's illustrative of a trend, gamification, which I think has actually profound implications for health and healthcare. So everyone here knows Farmville, right? Does anyone here know how many users Farmville acquired in its first 18 months? 73 million. It went from 0 to 73 million monthly users in 18 months. I'll submit to you the person who invents Healthville and gets 50 million plus people playing a game that they want to play, that's fun to play, that's habit forming, that helps teach them about health, by the way, as a side effect, that person will be one of the most important public health figures of the 21st century. Because they will do more to engage people on their health than all the Eat Your Spinach programs in the world combined. Because Eat Your Spinach has been proven to be a colossal failure when it comes to behavior change, as BJ would tell you. So listen to BJ and try to invent Healthville. And then the final example is one called Asmopolis. This is a brilliant example by an entrepreneur named David Van Sickle in Madison, Wisconsin. He took a GPS device, attached it to an asthma inhaler, and linked it to a web app. So every time you use the inhaler, it tells you and records where and when the attack happens, so you can see that on a personalized map of asthma incidents, and lets you and your doctor know that. There is a study that's about to come out on Asmopolis that showed that in the target population, it cut the rate of uncontrolled asthma in half. And I actually didn't know that 75% of asthmatics have their asthma in an uncontrolled state. So cutting that number in half is a big deal. I also didn't know that actually the difference between uncontrolled and controlled is $3,000 a year per person in healthcare costs per asthmatic because of lots of complications that happen if your asthma is actually not controlled. So that's a very, very interesting breakthrough. And there are these new provider organizations forming under the mechanisms that Medicare is rolling out to help incent quality and health. They're very interested in adopting Asmopolis to try to bend the curve on cost and quality. So the best thing about all of that, I have to wrap up quickly, is that the government actually didn't do crap. Yeah? Right? All the government did was take a bunch of data, make it really easy to find and use, and promote it to the right innovators, and then they did the rest. In less than 90 days, they turned it into a whole panoply of really cool apps that people are using, and that are helpful, and that can help grow businesses. Imagine if the government issued an RFP for any of those apps. And we can't say hello in 90 days, let alone actually get something like that to happen. And so this is a wonderful example of a public-private sector ecosystem that can drive a lot of value. So the long story short on HDI, on health data initiatives, that we're all in. We're going crazy. We're publishing everything that moves. We've greatly expanded the aperture, so it's not just community health and provider quality data, but essentially a whole bunch of data. Because if you think about HHS, it's Medicare, Medicaid, the FDA, the NIH, the CDC, et cetera. Tons and tons, literally billions of dollars of data that taxpayers have already paid for that we're now liberating. We're not actually freeing it up if it violates privacy or trade secrets, but everything else we're actually publishing. I could talk all day long about all the data sets, but I won't because I don't have any time. But actually, to make it easy, if you go to healthdata.gov It's a one-stop shop for all our free data and APIs. And we're adding to it more and more every day. There's a ton on there. My favorite tweet, because I monitor the Twitter stream pretty rigorously, is from an entrepreneur in Cincinnati, Ohio. His tweet tag was health entrepreneur in Cincinnati, something like that. And he actually said, looking at healthdata.gov, feel like a kid in a candy store, which I just love, because hopefully that's the feeling all of you will have when you check it out. And there's also a forum, so if you don't like a data set, think it could be improved, or see a data set that you would like to put on here that you know about HHS, just let us know. We're monitoring that constantly and would love to hear from you. And beyond just publishing the data, we're engaged in an extensive marketing campaign to publicize the fact that data exists. So we're doing a bunch of things like challenges. If you go to health2challenge.org, this is run by a partner of ours, Health 2.0, where any government agency, company, or individual can issue a public challenge for the best app that does X, like the best app that engages kids with health data, so on and so forth. 21 of these have been issued to date. They're very, very exciting. We're also doing codathons. Y'all know what codathon is? So it's where basically hackers get together over a weekend and build something awesome. So we're actually doing that as well. Do I have time for, I don't have time. No time. Okay. Well, this is a picture of one such codathon output, which I will not talk about, which is really cool. Dang it. Anyway, but real stuff is coming out of these things. And more importantly, frankly, the codathons and challenges are recruiting a whole new class of innovators into healthcare that haven't gotten involved before. There's only one thing I learned as an entrepreneur in my prior life that's actually a replicable lesson, company to company, which is this simple fact. If you get the best people, you win. If you don't, you lose. You may not actually lose immediately, but it's just a matter of time before you do. The same thing is true of ecosystems. If healthcare recruits the best entrepreneurs on the planet, it will transform. We will invent our way out of our healthcare problem. And so what we're doing, the reason why I'm here today is it's not because I like listening to myself talk. It's because there's this incredible opportunity to talk to the best innovators in healthcare and get you even more excited about doubling down, jumping in, taking advantage of incentive change, information liberation to change the world. And the final point I'll make is that at the end of the day, HHS doesn't want to actually control or drive this health data ecosystem, right? We just want to be a happy data sugar daddy and a cheerleader and a facilitator. But the whole point of this health data ecosystem and this broader health innovation ecosystem is for it to be decentralized, grassroots, and out of control, completely out of control. And frankly, the more out of control, the better. The latest exhibit in this is going to be something we're calling our Health Data Initiative Forum, which we're holding on June 9th. I wanted to call it the Health Data Palooza. Institute of Medicine said we can't call it that. We have to call it something more formal. I said, fine, call it the Health Data Initiative Forum, but it's Health Data Palooza. And what's happening is we actually, for our second anniversary of our Health Data Initiative specifically, we said we would like companies to come exhibit and talk about solutions they've actually built that leverage in part our data and mash it up with other data and other capabilities to help consumers make better decisions, help employers promote health and wellness, and reduce cost, help doctors deliver better care, help health systems transmogrify into accountable care organizations, help mayors make better investments, et cetera. So we had about 40 spots that we had. We were hoping to get 40. We ended up getting over 70 applications. They were all incredibly good. And even after we applied, our second test, which is not only does it deliver concrete value, it also must have a sustainable business model. It can't be a concept car that has no prayer of actually ever reaching anybody and helping anyone. It's got to be something with a sustainable, scalable business model that can actually serve people and scale to serve more and more people. Even after we applied that test, we couldn't really narrow it down. So we're actually now doing a series of American Idol-style virtual auditions where people are pitching a committee on their innovation. We're narrowing it down to 40. I'm Paula Abdul. I love everybody. Everyone's phenomenal and fabulous. My colleague Greg Downing, Simon Cowell, saying, you suck, that's terrible. But actually, it's hard to say that because, frankly, they're awesome. And so we're narrowing it down to 40 who will be showcased at the Health Data Initiative Forum on June 9th. I can't actually give away their punchlines, but what they've done is absurd. And that's why I'm so bullish about healthcare right now. It's not because I've been sitting in my office in DC thinking really positive thoughts to myself. It's because I've spent a lot of time in the last 6 months talking to hundreds of healthcare innovators, most of whom you've never heard of, who've already built stuff at the intersection of these two trends that is awesome. Stuff that collectively is going to transform the healthcare system. A lot of it will not work, but a lot of it will, and stuff that works will scale with the aid of these two mega trends, and we are going to invent our way out of our healthcare problem. American ingenuity will carry the day. And at the end of the day, HHS's role, this is my big message, we are not here to transform the healthcare system. We're not here to be the innovator, right? You're going to actually transform the healthcare system. You're going to be the innovator. Our role is to simply be a catalyst and a supporter, do everything we can to fan the flames of these trends and to help weaponize American entrepreneurs and innovators to transform healthcare at a speed and with a ferocity that I think will stun the world. And I'm already seeing it begin, and it's the most inspiring thing. So thank you so much for hearing me out.
Thanks, Todd.